I would encourage any physician who is struggling with worries about hopelessness, if they start to feel like they do not have joy in their life, if they start to feel so overwhelmed and so excessively guilty about themselves that they are a burden to their family or to their job, if they make mistakes, because we all, myself included, make mistakes at our job, that mistake perseverates to the degree where you feel like you cannot move forward. If any of these kinds of feelings come up, I do really, really encourage you to seek mental health care treatment.
Are you missing the hidden signs of mental health struggles in your own life or in your children's? As busy professionals, we often ignore our mental health, and worse yet, we may be overlooking critical warning signs in our kids. Today, Dr. Shivana Naidoo challenges us to rethink how we approach mental wellness for ourselves and our families. Dr. Naidoo is a double board certified adult and child psychiatrist with over a decade of experience in outpatient care. As a clinical instructor at Brown University's Warren Alpert Medical School and host of a podcast, Thinking It Through with Dr. Naidoo, she empowers parents to prevent youth suicide and advocates for improved mental health care. Welcome to the show.
Thanks so much for having me, Nate. I appreciate being here.
Absolutely. What's going well today?
Ooh, what's going well today? Well, today is the last day my kids are in school before fall break starts, which means chaos ensuing in my house. So what's well is the stillness with which I can record this podcast with you and the quiet before the storm. So that's well. And I live in Chandler, Arizona. So it's been really, really hot. If you've been watching the news, in the hundreds for many, many days, and it's coming down. Upper 90s today. So we're working our way down to being cooler and more tolerable.
There you go.
And it's funny because there are days where I'm like, why do I live here? It's so hot. And then days like today where it's just a little bit cooler, I feel like I'm in paradise. I feel like I hit the jackpot. So it's literally hot and cold feelings towards the
There you
heat.
go. Well, you got to appreciate it because I'm in Iowa. So like middle of December when there's a foot of snow on the ground and it's negative 10 degrees. But in Chandler, Arizona, it's like 75. Like,
right.
That's when you appreciate it. But today we're going to talk about a hot topic. No pun intended with the Arizona weather. But we're going to be talking about mental health and suicide. So I want to dive right in, if that's okay with you. So just recognizing those hidden mental health issues. So many parents might miss the warning signs of anxiety, depression, things like that with their children. What are some of those like subtle signals that parents should be aware of and better recognize if their kids are having some mental health struggles?
So it's really tough to be a parent nowadays. I'm sure every single generation of parent has said that about raising kids. But I think the aspect of really online engagement and that lending itself to kids disengaging from their family as a part of kind of natural development now makes it really hard to pick up warning signs. Because before, if Johnny wouldn't come to the dinner table, it was kind of like, oh, this is weird, right? But now it's like, well, Johnny's on his tablet, so that's why he's not here. So I think it makes it a little bit more complicated. But I think disconnecting to family, having shifts in the family dynamic with that child and teenager is a really important one. And we know that there can be kind of fluctuations in everyday engagement, but we want to look for the overarching over time. Is this a trend? Is this a trend that we see in this child? Changes in how much they're engaged in our family, changes in their mental attitude and approach to life. Like, is this kid not doing so well in school? Is there declining grades or failing grades even? Is this a pattern? Does it seem like your child's also disengaging from their own friends, right? So there might be a child who seems to have lots of friends, but then says, no, this kind of friend left me, my boyfriend left me, and they're just seeming more isolated on their own. That's another concern. And I also think two big signs that we don't often think of, but I think is important, is sleep dysregulation, which we know teenagers very often are prone to having messed up sleep. But when they are not able to fall asleep and stay asleep, that kind of level of insomnia, or where they're excessively sleeping so much they're not able to get up on time to go to school, or it's interrupting their their activities of daily living, like that is concerning also. So sleep challenges that do seem to really impact them, as well as anxiety, high anxiety. So overly thinking about things, getting very stressed, seeming to avoid things because they're so stressed. And I bring those two things up because those are also two very big risk factors for suicide in the adult population, high anxiety and insomnia. But I think because it is a very typical thing for people to experience anxiety and sleep dysregulation throughout their life, but particularly as a teenager, I think those are some signs that can be really missed. So I tell parents, and I believe this is on my website or in my podcast, the acronym FIND can be very helpful to think about whether this change is something that is worth really being concerned about. So F is if there's any change you see in your child, whether with their attitude, irritability, anxiety, insomnia, how frequent is that change? How often does it happen? Is it every day? Is it every week? Is it only on the weekends? So how often? That's the F. I is for intensity. How intense and strong is this shift? Is it, that they're sleeping through their alarm clock? Is it that they're sleeping through football practice? Is it that they can't sleep at all, so they wake up with bags under their eyes? Or is it just that they say they can't sleep, but you walk into the room at 1 a.m. and they're snoring, right? Like, how intense is it? And then number is the number of times it occurs in a phase. So you might have certain phases because kids, they go along with the school schedule, right? So they might be on a certain schedule when they're in school, like my kids are now. And then I know I'm shifting into a phase of fall break. So all bets are off. They're going to be off schedule. So what's the number of times it occurs in a particular phase? And then finally, D stands for dysfunction. What is the level of dysfunctionality it's causing in the life of this kid? Because again, if it's impairing their life, then you definitely want to make sure you take that child to see a pediatrician, run it by them, because they are the experts in what is typical or the normal variation of kid, right? So they're seeing all kinds of kids and they can tell you and double check with you, like, is this just an expected phase of their life or is this something more?
Absolutely. And as you were saying all that, and that's a great acronym, by the way, so thank you for sharing that. Just thinking through some of those phases, because you mentioned like the teenage years, football practice, things like that. I think if you remember back to that period of your life, and I think of that period of my life, like just all the changes that are going about, whether it's,
Absolutely.
That change from elementary school to junior high to high school, from going from one school on one side of town to another, changing friends. Like there's a lot of factors, social factors, I think is where I'm trying to go with this, that can play into some of those things. And so it's got to be hard for parents to really recognize some of the things that you mentioned, some of those struggles, or what are some of those signals that we should be looking for? Because some of those could just be like, hey, you just went from junior high to high school.
Right.
That's a big change. Maybe some of your friends, went to a different high school and you're feeling a little isolated. What do you say to parents that are like, this is just pretty normal for the season of life that my kid is in, versus no, this truly is a problem?
Well, I think the question of whether it is a typical expected change versus whether it's something that deserves more attention is a really important question, right? We don't want to over pathologize kids or label them with a diagnosis that they may not actually deserve or need. So as a child psychiatrist, we are trained in making assessments throughout the lifespan, but we always think about those phases, those known transitions of life, like you mentioned, between different grades or schools, elementary to middle school to high school to college, huge, right? And during that phase, give yourself a little grace, right? So, I had a parent speak to me recently about her transition aged youth kid who's in college. And he's calling her on the phone. He's freaking out. He's like, Mom, I'm not doing as well as in school as I want to. What's going on? And she's like, dude, chill. It's been 3 weeks. You're going to have a tough time. Let's sit it through. Let's talk to Dr. Naidoo and we're going to sort it out. But it's going to take you some time. So I think it is very valuable when parents who know their kids better than me, right? They're going to know their kid better than any doctor that sees their kid. Is this something that is typical for my child? Do I anticipate this transition causing some stress or dysregulation? Or is this really not typical for them? They don't react this way because that's not how my kid is. Like you have 3 kids, right? So I have 2, my boys, Gavin and Dylan. They have the same parents, but they're like totally different people, totally different emotional content. They react to life differently. One of my kids is a total firecracker. He's very emotional, very volatile. And the other one is like smooth sailing, calm, You just never
I got
know
two of
what's under the
those. Yeah, I got
surface.
two of those as well.
So, if my cool, calm kid starts acting up, I know something's off for them. But if my
Mhm.
volatile kid is acting up, that's not atypical for him. So sometimes you do need an expert like a pediatrician or a psychiatrist to kind of just think it through with you. But again, I think going back to that D and find the dysfunctionality. Is this causing dysfunction? Because if it is a mild episodic shift over the course of a couple weeks, a month, 2 months, these things will even out, right? And oftentimes things can get bumpy, but it's not a break in the bridge, right? You can
Mhm.
still travel on the road. It's not preventing you from doing what you need to do. So I think that's also really important, what level of impact it has on the life functioning and success of that kid.
Yeah, so let's say a parent is going through that exercise, the FIND kind of thought process, and something's off, right? So, like, how should a parent decide between investing in, I'm going to use some big words here from my psychology minor that I have, like neuropsychological evaluation, psychiatric evaluation, basic therapy, versus maybe an alternative treatment like just coaching? Like when should
Mm-hmm.
they decide what type of investment they should make in one of those types of things? And like what criteria would you recommend parents consider? Like as they go through that FIND, is it, hey, this is pretty atypical, this is normal, or no, I need to find some professional help?
So that's a great question. And I think that it's really important that you ask that because it is so confusing, right? Like
Mm-hmm.
we don't know where to go when we need help with our kids sometimes. And on the other side, a lot of parents really don't want their kids to be stigmatized, right? You want to
True.
be as understanding and supportive of your child, but you also don't want to mislabel them. As I said, I've said this before, because I think that we're we are moving in a direction where kids are overly diagnosed. That's partially why I went into become a child psychiatrist. I went in child psychiatry in part because I feel like we're over-diagnosing and over-medicating our kids, right? We need people who are
Mm-hmm.
thoughtful and mindful of change and when and if and how to be really just cautious about when we put that label on because that label affects our children's identity. It affects who they are, who they believe they can be. I have a blog post up called The Cactus Kid and how, every kid's a rose, right? Every kid's developed this beautiful bud. We're hoping to unfold, and just share their fragrance with the world. But sometimes life gets hard and that causes some kids to develop prickles, right? And
Mm.
those defenses are really hard to deal with as a parent. And I think sometimes when we label them, it is hard to see the rose inside, right? That kid really truly is a rose, even though they're looking like a cactus. So I think that, how do we figure out if they've changed truly to a cactus, if they're diagnosable or not? So the first step should always be your local pediatrician, your friendly pediatrician who has an alliance and a trust with you as the parent and hopefully the child long before these issues come up. Because that pediatrician, by the virtue of having them been involved in your life over time at these touch points, right, their annual physical or even during sickness, they can tell if this is something that was brewing, something on their radar, or something that's totally not. And that's very worrisome. So I always would start there. I think another touch point for a lot of kids are through the school system, because very often if kids are struggling in school academically, the school may offer something called a psychoeducational assessment, which is typically done before certain levels of support like a 504 or an IEP, which are through public education. These are adaptations in the school setting that can be made to help your child succeed, which is
Mm.
required by law if they have certain diagnoses that are medical and mental health or learning disabilities. But in terms of a neuropsychological evaluation, that's the highest end of a diagnostic eval. So those are typically
Sure.
done by psychologists, not psychiatrists, and there are many, many tests. It's many, many hours. So oftentimes that's not the first thing that we jump to. But I think for certain physicians and people in certain socioeconomic brackets who are more aware in general, they may have the ability to pay for a neuropsychological eval, and which is oftentimes expensive and time
Mm-hmm.
intensive, but then kind of have that gold standard, I'm putting quote unquote gold standard there so that they really get a sense of what's happening for the child. But I
Yeah,
say
that's
in quotations gold standard because there are times that I've sent kids for psychological testing and the diagnosis that they come up with is not what I agree with clinically, right? And we still have to
Mm,
put our heads together and see what makes the most sense in terms of how to help this child.
yeah.
I would typically say in terms of diagnosis or understanding if there's a group of symptoms that meet the criteria for, a DSM criteria, which is our diagnostic kind of Bible. I would not go to a counselor or just any therapist, again, quotations, like you really need to go to a psychiatrist who's an MD or a DO, who's licensed and certified, board certified, should go to a psychologist who's a doctoral level of providing therapy and diagnosis. Both of us have been trained in diagnoses, although lots of different types of therapists, like licensed clinical social workers, may be able to do diagnosis as well. I think the doctoral level of assessment would be, in my humble opinion, the wisest thing to do because they have specific training in that and they're very thoughtful and cautious about how that's gone about. But you should
Mhm.
always start with your pediatrician.
For sure. What does that collaboration look like then between, if, like you said, you've sent kids off for maybe a neuropsych eval or just a standard psychiatric eval, um, and maybe that diagnosis doesn't look like what you were initially thinking. Like you're
Mm-hmm.
essentially sending them off to do a little bit more rigorous testing, kind of a second opinion
Right,
in
right.
your mindset. What does that
Mm-hmm.
collaboration look like once that eval has been completed and there's kind of that, okay, what's our next steps moving forward?
Right. So oftentimes a neuropsychological evaluation, which can be very extensive, and oftentimes
Mhm.
is done for the more complex kids. So as you said accurately, like having a second opinion or a more thorough deep dive into issues. So let's say there's a kid that had high anxiety and we're overthinking. And in my mind, I'm seeing the kid and I'm saying, maybe it's not just high anxiety. Maybe they have OCD.
Mhm.
Maybe they have some form of ADHD. Maybe there's some mild autism spectrum in here that's making them so stuck on their anxiety. And my clinical assessment, which is all you really need for most diagnoses, is still, again, I'm trying to be clear. I don't want to mislabel someone. So I send them for a psychological eval, a neuropsychological eval. It depends on where they're located. So where I've worked in the past, I've worked in academic medical centers, which is really a fantastic place to get a good assessment because you have all kinds of different specialists in one spot. And
Mhm.
oftentimes they take insurance. So it's less expensive for you because you go through your insurance. So in that setting, I was able to speak with the psychologist who did the neuropsychiatric psychological evaluation and talk to them about my thoughts about their assessment, my assessment. We put our heads together. And at the end of every neuropsychological eval are like 10 to 20 different recommendations. They always do a very good job of not just explaining the thought about how come they came to this diagnosis, but they also come to a place of making the intervention recommendations, which may or may not include medications, may or may not include school adaptations. But that's a place where we can collaborate too. So with that neuropsychologist, we talked through all of those recommendations and then also the message that I'm going to now share with the parents about what that was. If they're out of the system, then it really depends on whether the parent, who for a minor, someone under the age of 18, and it depends on the state, but in general, under 18, they have to provide consent for me to talk to that person. So if they say, Dr. Naidoo, we we thought that neuropsychologist was not seeing what we see, like we're going to go with you, that's up to them. If they want me to be able to communicate with them, then I will, but I have to get permission before I can do that if they're outside the
Mhm.
system. And I think one thing I want to say about neuropsychological assessments, and again, this is an assessment that I do not do, right? As a psychiatrist, as an MD, I'm not trained in this. There are some psychiatrists who have specialized assessments and testing. For example, I have been trained in the ADOS, which is a specific form of testing for autism. I don't
Mhm.
always use it and do the full ADOS, but I use those some clinical pearls from the testing when I'm assessing clinically for a diagnosis. But as someone who does not do that type of testing, for the person listening, it is a neuropsychological test is essentially several different surveys that are validated that parents will do, that children will do, and from the data of that survey, it helps to push for or against certain diagnoses to help the neuropsychologist pin down what may be happening. And they also have to do a clinical assessment. So they're doing kind of like a talk therapy session, talk assessment like I would do, where I'm just talking to the parents and the kids and I'm ticking off the symptoms in my head, but having a conversation with you, that
Mhm.
is a clinical assessment. So they have to do both. They have to put their clinical head together and the testing results together in order to actually put that diagnosis on the paper. So it's not just, a checkbox, yes or no. It's not like the test is all or nothing. They do recognize that there are clinical assessments that are a part of putting a diagnosis on there. And where I work now, I work in a virtual PHP program called the Bradley Reach program. It's a virtual kind of higher level of care. And because, again, it's attached to Brown University and it's academic, the neuropsychologist there will join our team meetings. So when we ask them to do testing, they'll get feedback from me as a psychiatrist, as a therapist, as a family therapist to get a sense of what else might be happening that they didn't see, but can inform their diagnostic impression.
Sure. Well, that's really good insight. Um, Thank you for sharing that, because I think that's something that people don't see that on the back end. They go to a professional and they say, okay, create a diagnosis or tell us what's going on, and then we move forward. But I think that's good insight to understand. Like there's a lot of collaboration going on to make sure that the diagnosis is accurate. Which, as you were saying all that a couple of minutes ago, you talked about you don't want to mislabel a kid
Yes. Mm-hmm.
or misdiagnose, and I think that's super important. I say super important just because far too often in society today, a kid is acting out and they automatically think, oh, that kid has ADHD. Like
Right.
he's got to have it. Like, and that's kind of the stigma these days is people just kind of radically throw that acronym around. Let's say that someone is a child or an adolescent is accurately diagnosed with a mental health issue. They The parents have recognized even some suicidal thoughts. There is that stigma, right? There's that societal uncomfortability that kind of comes with that. Parents feel it. The kid might feel it having that diagnosis, brought to them. What are some of the more effective strategies that parents can use to, what's the word I want to use? Like protect that kid, both emotionally or even practically?
Yeah. So also a great question. Before I tackle, I just wanted to mention, along with the ADHD diagnosis, I think society has used lots of labels kind of like flippantly to
Mm-hmm.
describe people. Like OCD is thrown around like this. Bipolar is thrown
Yep.
around like this. Anxiety is. But I think, ADHD, OCD, bipolar are thrown around and manic, right? People will say I'm manic, very often.
Yeah.
And I think that compounds the difficulty with really sorting out, is this an endorsement when you're listening to a history from a parent or a child? Is this how society has told them to think about this symptom, or is it actually their symptom? And I think that's
Mm-hmm.
the meta skill of being a psychiatrist and I think a physician, right? Listening through the narrative that the patient presents to actually ascertain what the symptoms are, which is not necessarily what they're saying, right? Very
Mm-hmm.
often I'll have parents say, my kid has anxiety, but really they have an anger challenge, right? My kid has poor concentration, they're not motivated, they have ADHD, but actually they're depressed. So it takes an expert sometimes to put those pieces together to figure out what actually may be going on. And I think sometimes how parents will talk about their children and kids will talk about themselves is also wrapped into society's way of kind of minimizing and normalizing certain diagnoses, which really isn't always accurate or helpful.
Mm-hmm.
And I
Yeah.
think for this generation of kid, that happens with suicidal thoughts. I think a lot of this generation, Gen Z, say, I'm suicidal, I want to die, very much more often than I think prior generations. And I think
Mm-hmm.
sometimes it's hard to tell for parents as well as for schools and for peers and friends, like, does this kid really mean this or not? And I think that that doubt sometimes can delay intervention. And I understand why the doubt is there because it's used so often. And I think, again, Gen Z is much more open about their mental health care needs. I think COVID-19 really broke down lots of barriers about really letting people acknowledge that, yes, I have a challenge and I need help for it and I'm going to do something about it. So I think that's one of the benefits. And it also has helped open up telehealth for mental health,
Mm-hmm.
which I think there was still so much resistance before. I think after COVID, everybody is now jumping on the telehealth bandwagon. But
Mm-hmm.
for parents who have a child who think their kid may have suicidal thoughts or are worried about that, the first thing that you should do as a parent is, I think, try to have some kind of communication and conversation with your child about it and see where that goes. And that is going to be a difficult conversation to have. Like, it's going to be difficult. And that's why I have a workshop called, Empowering Parents to Prevent Suicide, because I know that is the hard thing. That is the hard thing for parents to do, to actually manage their own emotions. Because if you're a parent and you hear that your kid has suicidal thoughts, your mind's on fire, right? Like, you're not thinking, you're scared, you're worried. And that's also why I created this workshop, because that's what would happen in my outpatient practice. I would see so many kids and parents. And because I'm a child psychiatrist, as the name says, I'm focused on your kid. That is my patient. So I'm doing everything I can to put out their emotional fire. And I'm trying with every extra time I have to do it for you, mom and dad, but I don't have the time because I got my next patient waiting. And this is the challenge happening in outpatient mental health care that takes insurance. We don't have the time to help address the parents' needs. And they have very valid needs. They need support too, because when that kid leaves my office, where are they going? They're going to mom and dad's house. They're going to their guardian's house. So the guardian has to make sure that they're able to have the emotional reserve and the persistence to continue to engage that child and keep them safe. So first part, I think, is having a conversation. If that kid wants to talk to you, fantastic. You continue to have them open that door up and share and listen. And your goal is to be a receptive vehicle. I'm here for you. I hear you. I see you. You are valuable and important to me. I love you. That's the message you want getting across to your kid. The other thing that is the only thing that parents and guardians can do. I can't do it for you as a psychiatrist. Your therapist can't do it. Your counselor can't do it. This teacher can't do it. Is to mitigate or reduce access to lethal means in your home. That is the only thing parents can do. So I have an acronym called Go Secure. That acronym stands for this very quick way to go through things in your home that are the highest yield and that can reduce access to lethal means. So G stands for guns, right? Clearly, guns are the number one way that youth kill themselves if they attempt suicide. So if you have guns in your home, please do lock them up, have them separated from their ammunition, make sure they're safe. The safest place is, of course, outside of your home. So guns are number one. And then O for the go is overdose options. Overdosing is the number one ways that teens attempt suicide. So this is locking up prescription pills, over-the-counter pills, vitamins, cleaning supplies, anything you can think of. And especially if your child has gravitated or tried something, that's the thing you want to make sure you lock up. But I say vitamins as well because I've had a kid destroy her liver because she overdosed on iron tablets. She needed a liver transplant. So things that we think like melatonin or Benadryl that could be safe may not be safe. And Advil and Tylenol being the most important one, is very, very deadly. So you want to lock up all pills. That's O. S for secure stands for sharps. So sharp objects, knives, X-Acto blades, the sharpener inside of pencil sharpeners, that little blade, that can be used for self-harm and cutting, which is separate than suicide, but very often kids that do self-harm and cut, they are at high risk for suicide, though it doesn't mean that every time they cut it means it's a suicidal statement. But S stands for that. E stands for electric cords or things you can use to hang yourself with. That's the number 2 way of completed suicide in youth in America. C stands for car keys. So oftentimes kids will take their cars, go off in the middle of the night, or they'll leave the car running for carbon monoxide poisoning. So if you have if you have an indoor garage like I do now in Arizona, I didn't in New York City when I lived there, but you want to make sure your car keys, your kids' car keys are locked up. U stands for underage drinking. About 50% of kids that come to the hospital in a suicide attempt have alcohol on the brain. And for those of us who drink alcohol, we know that it does disinhibit us. It impairs our reasoning. And in American homes, most homes have alcohol as easy access. R from Go Secure stands for reattempt. That is where kids who have tried to attempt suicide that same year are 60% likely to try again by the same method. So if they tried to overdose, that's the one thing you want to focus your energy on. If they tried to cut themselves, that's the one thing. So just make sure whatever they attempted, if you have a kid who did attempt, you really secure that. And then the last E stands for exits and entrances, which is if kids think of elope or jumping off of something, that's something to protect against. So if a parent can do that one small thing, that can save your kid's life. And I mean, there's so many stories about young kids who were engaged in some online activity and their parents didn't know about it, and something triggered that kid and they snapped and they did something.
Hmm.
And it's horrible, horrible story, because we can't always predict with teenagers what they're going to do, because teenagers are not fully formed, right? They're a work in progress. Their brain is still growing, and your brain matures back to front. So this front here, this prefrontal cortex, the part that helps you stop and think before reacting, the part of you that is your editing mechanism, the part of you that weighs consequences, that's not fully formed till you're 25, right? So most 14, 15, 16-year-olds, that part is not responding the way that it really could, the way we adults would. But their amygdala, the part of their brain that creates and responds to emotions and high experiences and risk, that's all on fire, right? So they may overreact to a perceived threat or emotional experience and do something that really could be dangerous. But if you, as the parent and guardian, made sure Tylenol's locked up, guns are locked up, like these things are gone. I feel like this should be a part of everyday conversation, along with talking about the risk of unprotected sex and substances and social media and suicide. Like all these S's, these four S's, this should be a part of just anticipatory guidance that pediatricians provide, because this could save your kid's life.
I am super excited to introduce to you the Doctors and Dollars 5-Day Financial Challenge. I'm Mike Neubauer, I'm CEO of Grand Vision Companies, and I'm the one that you see on the Wealth Wednesday and Daily Dollar episodes with Nate. So Nate and I are partnering again to do something even more exciting, which is the 5-Day Challenge. We're taking the best of all of our episodes, all of our expertise and knowledge, and we're condensing it into an impactful and purposeful 5-day presentation, 1 hour per day, for 5 days, to give you everything you need to build that foundation for your financial future. So if you're looking to gain the pieces, you want those puzzle pieces and find out how they fit in your financial plan, head over to the Doctors and Dollars website, join us on the 5-day challenge. We're putting it together for free, so you got nothing to lose. We look forward to seeing you on the inside.
Absolutely. Another great acronym from you. So thanks again for sharing that one, because that's really good. That's very helpful information in understanding what are some of the prevention items that parents can do. My thought then goes to, like, maybe this is, I don't know how old you are, but like, this just wasn't, maybe it wasn't talked about, or it just didn't seem as prevalent when I was in junior high or high school. In the late 90s, early 2000s. Like, it was just not really a thing. Like, you mentioned COVID earlier as maybe one of those factors. What are some of the other reasons why you think, and this is speculative, of course, but like, what are some of the other reasons that you think that this has become more of a social norm, or something that everyone is hearing about now versus, let's say, a decade or two ago?
Well, I don't think I'm that much older than you, but I'm younger than I think some of your guests here. But I remember in high school, I went to a high achieving. I'm from New York City, right? So I'm a New York City person. I was going to go to med school, right? So I'm a straight A, like, perfectionistic kind of kid. So I went to Townsend Harris High School, go Harrisites in Queens, and all the kids that went to the school were high achieving students. And one of my friends from junior high school went to the same high school as I did. He was a year below me. And he committed suicide his freshman year. And I remember being on the bus, because we lived near each other, right? Taking the bus home with him. And we were talking about All Things Fall Apart. It was like a required reading freshman year in our high school. And in the protagonist in that book commits suicide. And he was talking to me on the bus about this and what I thought about this. And at that time, again, I'm 15, right? I had no idea what he was thinking. We were talking about it, the pros and cons, right? Just like you would in English class. I thought nothing of it. And then, days later, he ended his life. And so I bring that up because that was 24 years ago, like 2000, in the late 1900s, 1990s. And I think that not that far back, right? 1990s.
Don't age us that much by saying the 1900s. Oh my goodness.
Yeah, 1990s. But I think I bring that up because I don't think it was that uncommon. I just think we didn't hear about it. Because back then, if social media played the role that it does now, everybody in the school would have been talking about that and knowing about that, would have been everywhere. And it was already within that school, but every single high-achieving New York City public school would have known about that suicide. So I bring that up because I do think social media has played a role in sharing and spreading the need for youth to have mental health care help, as well as sounding the alarm for the attention being placed in this direction. And I think it also has created an opportunity as well as a potential danger zone for reaching out for help. Where I work right now in the Bradley PHP, we very often will have a young person come in because they posted something online that signaled to friends that they needed help. And that's not uncommon, because even though this child may have loving and supportive parents and siblings and friends, they may not feel like that group around them can hear them, can really address that need. So sometimes it turns to that. I also think on the flip side, I think our social interaction has become less rich than it was before. I think the depth of our connectivity has been, it's more superficial because of our online activity. I think we think about the volume of likes that we have and the volume of friends and take that to mean that we are so loved and liked. And then when we don't kind of get the actual acknowledgement and love and appreciation from these people that don't know us, it's a very big blow. I still remember the first time that a boyfriend that I had on Facebook blocked me, and I was a young adult. That was a very painful experience. I went off Facebook for quite some time. It was hard as a 20-something-year-old. I think I was in med school, 24, right? Like 24, close to that, like brain maturity, right? 25. It was very hard. So imagine a 13-year-old, right? Their girlfriend breaks up with them and then posts something online. Like, I do think that there's a world of potential danger as well as potential connectivity, right? There's the coin has two sides, and there's good and bad in it, but I think that it has really opened up a Pandora's box of the need for us to really look at how to support our youth in a more helpful and healthful way. Because I think sometimes those extracurriculars are not enough, right? Like, eating 3 balanced meals a day is not enough. Like, we need more. And I think it's coming from, in part, this paucity of connectivity, this epidemic of loneliness, right, that we hear about in young men. I don't think it's just young men. I think all of us have, and especially our younger generation, are really still striving to feel deeply connected to someone else.
Absolutely. Oh, great thought there. I do want to shift gears on you and
Sure.
talk about adults, busy professionals, specifically physicians.
Yeah.
Before we make that shift, I've one more question in the kind of in the realm of children and adolescents, and this is more of a financial based question, just for my own curiosity. But like, in your professional experience, is there any correlation between the wealth of the parents of some of these kids, whether that be poverty level or very affluent, as far as the volume of kids? So let's say you take the whole data set of all the kids that you've seen, how many of those families lead towards affluent versus more on the poverty level? And what do you think that correlation is?
So, I will be honest that my experience, I had lots of debt for med school, right? So I enrolled in a program called the Public Service Loan Forgiveness, which is where you work for a nonprofit organization for 10 years and then your loans are wiped off, which means my experience over the past decade and residency, where in residency you mainly work with poor people, is skewed towards those who are socioeconomically disenfranchised, right? So the lower socioeconomic status. Only now that I have a small private practice, I'm working with more higher income clientele. But I have lots of colleagues who work with very high end patients as well as concierge psychiatry. And, so from my personal experience, yes, those people who have, I'm not sure if you heard of the ACE score, which is the adverse childhood experiences and exposure.
Yep.
So the more of that, the higher that is, it tends that you have more medical complications later on in life and mental health care complications. So I do think not having enough money and being financially insecure is a tremendous impact on mental health and stress and anxiety and insecurity. Absolutely. But for my colleagues that work with the opposite end of the spectrum, there are challenges there too. And I think sometimes it sounds like the higher end group of those who have higher incomes, they have very different kinds of challenges. And sometimes they have even more pressures because the stakes are higher for them to achieve certain things, own certain things, have a certain level of fitting in with the Joneses that maybe other people
Sure.
don't have. But from my own personal experience, I cannot speak to that. But I think that more so than the actual amount of wealth, it is the perception of wealth. It is the perception of abundance, the feeling that I have enough. Because there are people that are very, very poor that feel like they have enough in their lives. They are wealthy and rich, even though they have very little in their bank account. And there are people that have lots of money that feel like they just need more and more and more and more, and they are not enough and will never get enough and never be like mom and dad and grandma. So I think it is this kind of satiation with where things are. And of course, we also want to strive for more, right? Like my private practice is called Do Better MD, right? I believe we can all do better. We can all improve. So I think there is a sweet spot with which to be content and grateful for what we have and strive for self-improvement.
Absolutely. Great. And that's the answer I was hoping you were going to give. Kind of that, I had a feeling it was that perception of abundance that you said.
No, and I think that perception of abundance does also lead to depression and anxiety, right? So many adults that I work with who have severe depression, have severe anxiety, it is a scarcity mentality that's in there, right? I feel like I can never find a partner. I feel like I'm never going to be enough. I feel like the world has just shafted me my entire life and there's no way out. It is a mindset about whether they are capable of holding on to abundance or worthy of receiving abundance. That's I think, a factor in a lot of mental distress.
Absolutely. No, absolutely. Shifting gears to busy professionals, adults. Specifically, I want to talk about physicians. Just that's most of our audience with doctors and dollars. You probably know this statistic better than I do, but like if you look at all industries, all professions, physicians have a high suicide rate compared to many other professions. Starting kind of at the lower end of that, like if suicide is the highest level that we want to talk about, starting at some of those lower levels, like we talked about ADHD earlier. I talk to physicians every day. Like that. Besides the podcast, we work with them within our Grand Vision family office and the investments and stuff that we do. But many physicians they juggle overwhelming workloads.
Yep.
How can someone differentiate between maybe having ADHD or just simply being mentally overloaded, as a busy professional? What are some of those key signs that they should be looking for to make that distinction?
So it's really interesting because I think that as high achieving individuals, as people who continue to strive to do better and want more and more and more on their plate, I am one of those, right? Like people. I think it's a challenge because I think there are a lot of people, again, a lot of other systems of care that feed on us as physicians and high achieving individuals and know that if we want an ADHD diagnosis, we can get it.
Sure.
I'm saying that because I think there are some, I'm not going to say a lot, but I believe that there are some diagnosticians who don't have that same level of integrity and rigor as some the others. And I think that for the physician or for the high achieving individual who actually wants to be critical about whether this is true or not, I think first, before thinking about a diagnosis of ADHD, is how am I feeling about the load I have put on myself? What are the things I've put on myself? What are the things that are actually there? Because for any of us who are parents, half of our plate is full of them, right? Like with all the responsibilities. And if not, if we've been able to outsource that with a nanny or with other family members, your mind is still juggling those things, especially if they have a challenge, like a physical challenge, a mental challenge, they're not doing so well in school. So I think that's the first question physicians should ask themselves. And the second question is this something I've been dealing with my whole life, or is this something that has only started happening now? And I think Dr. Lola Day, who I think you've had in your podcast before, who's an ADHD coach and a physician, I think when she tells her self-realization story, she recognizes I kind of had this problem for a long time and I just ignored it. So she has that level of insight. And I think for those adults who are diagnosed with ADHD, they typically know. They know and they push it down versus those who are like functioning really high at some point and then all of a sudden there's a crash. And I think that there is more of a reason for us as high achieving individuals, as physicians, to ignore our mental health, ignore our medical health as well, because we know that we have debt, we know that we have a limitation of time, and we know that, we need to put our all of our hard work to use right now and capitalize on our energy and efforts to make as much income as possible. I think most physicians have some kind of a mindset along there. So I think that it takes some level of self-reflection and distance from your level of productivity to know, okay, was this really a problem forever, or is this really new? Because if it's really new, it is less likely to be ADHD, and more so with the load you're adding on. But if it's been a long-standing challenge, that is something that more likely is ADHD. And, I had an adult patient that I took care of, and she had been one of those high-achieving individuals. She's a teacher, and she was pushing. And when I saw her, I said, girl, you have adult ADHD. We need to treat this. And we treated it. And, it's been like a decade later, she reached out to me and said, thank you. Thank you for validating that life was so hard. And like with this one medication, it has revolutionized my life. And she doesn't take it every day, and she doesn't take it all the time. But when she does, she can be her best self. She can show up for the world the way she knows she was meant to be, versus just struggling and pushing against concrete. I hope that's helpful.
No, that was helpful. It definitely prompts my next question that I just thought of, is like, at what point should a physician consider seek professional help? Like, do they wait until they're like at the precipice of burnout, or should it be like, most physicians have the frontal cortex, or whatever it is that you mentioned, is now fully formed. Like, they can make good logical decisions. They are medical professionals. I do think there's probably still some of that internal stigma of like I'm supposed to have all my stuff together, right? Like I'm a physician. I'm well respected in the community. I make a good income. There's all the different factors that come with that. But like, at what point should they really be introspective and reflect and say, hey, there could be something here, and I need to seek some professional help, and whether that's simply therapy or that's medication or whatever that outcome looks like.
So,
is there a right time or a wrong time to really seek that help?
So I think it's really complicated for practicing physicians who work within a medical or mental health care system. And I say that because if you're a doctor listening, you know that before you applied for your position and got it, most places ask you, have you ever had a medical condition that could impair your functioning? Have you ever had a substance abuse problem that could impair your functioning? Did you ever have a mental health care condition that could impair your functioning? You're not supposed to ask these questions. But for physicians, there is very often severe reprimanding if you have engaged in mental health care, substance abuse treatment. So it really drives a lot of physicians away from seeking their own mental health. And I do think that that's what also makes a lot of physicians seek concierge or separate private pay when they see a psychiatrist, because they don't want it to be attached to a medical system where they can be found and it goes through insurance. It just makes it a little bit more easy to find. I'm saying that not because I want physicians to avoid, but because I want them to be able to know that there are physicians like myself who are in private practice, who are outside of that trackability, because I don't want you to wait till it's too late, right? I want you to be able to seek that help proactively. But, I will say, I think for physicians, there's a saying that physicians are the worst patients, right? Because we already know what you're supposed to do. We just don't quite do it, right? And, for myself, I mean, I have pre-diabetes. I have been working on this for 10 years, and it's still really, really hard. So I think like any chronic medical condition where you're trying to be preventative and proactive versus where it's at a point of true pain, it's hard to take action. But I would encourage any physician who is struggling with worries about hopelessness, if they start to feel like they do not have joy in their life, if they start to feel so overwhelmed and so excessively guilty about themselves that they are a burden to their family or to their job, if they make mistakes, because we all, myself included, make mistakes at our job, that mistake perseverates to the degree where you feel like you cannot move forward. So this is all before suicidal thoughts, right? If any of these kinds of feelings come up, I do really, really encourage you to seek mental health care treatment. And that treatment does not necessarily need to be a treatment. It could be a consult. You could meet with one person, and I would again start with your primary care provider if you have one. I would start there
Absolutely.
because they're generalists, but they know when it has met a threshold of something more. And then they can encourage you and prompt you to see someone else. And of course, if you as a physician have that insight and you know you need something more, you absolutely can go and seek that. But I think always start with like those three things I think would really concern me. And I would want you to seek help. And
Absolutely.
again, dysfunction, right? Going back to find. If there's
For
a level
sure.
of
And
dysfunctionality, then yes.
you kind of said it right there. Like as a physician, you can recognize those problems. I think the biggest emotion that comes into play, and you might agree with this, is the emotion of denial. Like
Mm-hmm.
denial can be a major barrier
Mm-hmm.
addressing mental health challenges. So like, how can people recognize and overcome the denial, of their own unhealthy habits or structures or whatever's playing those factors in their life, and really begin to engage in like meaningful change?
Yeah, and it is hard to stop the rat race and pause and look at yourself.
Bingo. Yeah.
It's really hard to do that because so many of us, it's been ingrained. I mean, I live in Arizona. I'm from New York, and I feel like people are like, what are you drinking? Like, why do you have so much energy? And it's because the New York is imbibed in me, right? I am a New Yorker still, so.
Yep.
As a physician, I think we are just pushing ourselves. We're at the grind. It's been built into us. So when we stop and take a pause and look at ourselves, I think we have to be okay with seeing the good and the not so good. It doesn't mean it's bad, but the
Mm-hmm.
not so good can really be fertile ground for change in the positive direction. But you have to be at a place to be okay to say, yeah, I'm flawed, and yeah, there's more that I can do for myself, and yeah, I need help. All of those are really difficult things to ask for.
Absolutely. So you have the private practice, right? Do Better MD. I always like to ask my guests as we wrap up the show, like, what do the next 5 years look like?
Oh my
Uh,
goodness, the next 5 years, wow. Well, I have to say, Nate, I'm asking myself the same question. I am fortunate to have, you mentioned coaching, and I will just briefly say I think a lot of physicians turn to coaching to help them achieve goals, which I think is fantastic. And coaches are not therapists, right? So if you are having hopelessness, helplessness, suicidal thoughts, please do not go to a coach. Please find a therapist. Please find a psychiatrist. They are different. They have
mhm.
different specialties, and get the right kind of help. But I'm seeing a coach, and I'm saying that because I just earlier on today got off my call with the coach and was like, what am I going to do for the next couple of years? I need your help. um, I think I have a lot of things in mind. I think one thing that's top of mind right now is that I feel like my kids who are 6 and 9, I really enjoy them. And I want to be able to create the memories and connection that is life saving and preserving and also
Mhm.
joy filled, right? Like I enjoy my kids. I also, get frustrated with them too, but I enjoy my kids and I want to soak up all that sunshine while I can because they're two boys. And I feel like the time will come where they say, I don't want to talk to you, mom. Room, door to their room is closed and they can't stand me. So I want to invest in that. I really would like to do more parent coaching of kids that have parents that have kids with suicidal thinking because I think we
Mhm.
don't have enough support for parents. I have visions of doing like a huge like online program. I have visions of, I'm a singer songwriter. I play the guitar. I have visions of, doing a singer songwriter group for kids that are dealing with these issues to help,
Sure.
again, help them write their swan song, help them write
Hmm.
a new way forward. I I have lots of different ideas. I don't know. I mean, I'm also engaged in working with pediatricians to help them deal with this mental health care crisis by providing consults for them. So I do that as well. So I'd be very happy to work with pediatricians because actually more than psychiatrists, they are getting the brunt of, the wave of the onslaught of mental health care. And they have far less training than we do because they don't have a requirement for mental health care oftentimes in pediatric residency. So I think that they're really struggling because there's not enough psychiatrists or therapists and there are long wait lists across the board. So I think that supporting them is what I'd also like to do. But, I think develop my talents, build some wealth. I'd like to build some wealth, right? Like,
There you go.
I mean, our kids are our greatest asset, I think. I know sometimes kids are thought of as liability, but I think that they have so much value. Like just, my kids holding my hand and wanting me to give them a kiss before going to school, like such power and value to feel like they need me, they want me, they appreciate me, and I
Hmm.
can make their day better by giving them a hug and reassuring them to get out the door. Like
Sure.
I think that there's so much value that we have in being a parent, and it's a fortune that I have, right? Some people don't have that luxury. It's hard for a lot of people to have kids. So
Hmm.
I'm rambling, but those are the thoughts top of mind of what I want to do in the next
That's a
5 years.
lot of
Many
things.
things, many things. I
I think
want
the
to.
part, yeah,
No, no, no.
I think the partnership with pediatricians is good. I was actually going to ask you if you were going to create some type of online platform, like the Do Better MD thing is great. I feel like you are in the Phoenix metro, right? And so a lot of your work is down in that area, and so it's like your message and what it is that you believe in, and really I don't want to call it a niche. It's not a niche market, but like what it is that you specialize in, where your truest passion is around the country. Like that
Right,
is happening everywhere outside of the
right.
Phoenix metro. And so, yeah, if there's some type of online platform where people can find you to interact with you and get your expertise and your guidance, I think if you could provide that resource to people, that's you're going to change a lot of lives doing that.
I hope so. I mean, my website is Do Better MD. My podcast is Thinking It Through with Dr. Naidoo, child psychiatrist. You're welcome to take a listen. And, I do hope maybe one day to think about some kind of online educational program. I have that workshop that I do have for parents
Hmm.
to take. It's on demand. But I think the challenge, as I said before, is that, as we talked about before you came on, is that the challenge with suicide is that it's not a problem till it's really a problem, right? So
Hmm.
it's kind of hard to get parents aware of being proactive and looking at it from that lens. But that's kind of where I'd like us to move, just like talking about certain risky activities. I think thinking about suicide is one of those things too. But
Absolutely.
I believe that part of it's just getting the information out there, right? That's why my motto is, know better, do better, feel better. You got to know better, you got to know about it to turn it into
Hmm.
action, which we know is hard. That's why coaching comes into play. You got to turn it into action. But then from that action you start to feel shifts. From that action you start to feel better. So it is connected, but that knowledge is the first part. Being aware of it is that first part. And that's why being on podcasts like yours makes sense, right? Because then you
Yep.
broaden your audience of who can listen to you and who can get that message. So thank you for having me and giving me that opportunity.
Absolutely. I'm glad we took some time out of our day to have this wonderful conversation. I look forward to when our paths cross again in the future.
Absolutely. Me too.
Take care.
Be well.